Good morning. It's an honour to be here with you, and for this part of my journey across my book tries to make a bridge between different specialisms, and there's no bridge.
Dice, mi libro está tratando de hacer un puente entre distintas especialidades.
And the aeroplane had to be the bridge for me to join you.
El avión fue el puente para poder hacer que estuviera junto con nosotros.
But the papers that I received before coming in readiness for today made me feel I'd already crossed a bridge into somewhere that felt like home.
Dice que los trabajos que recibió previamente a viajar lo hizo sentir que ya había cruzado el puente y que estaba en casa.
Stories only the body can tell. The particular focus of my presentation today is the importance of recognizing that the impact of a patient on a practitioner can take a physical form, which may be experienced as a physical sensation or a change in physical functioning. This falls within the broad range of what is called the somatic countertransference, a term often used not only to describe manifestations which fit with Freud's classical description of transference and countertransference, but also those aspects of the impact on the practitioner which emerge from more primitive states of mental functioning and which are more correctly explained by mechanisms such as projective identification. The key consideration is to identify those physical experiences which emerge in the practitioner through their relationship with the patient. This requires what Reich has described as evenly hovering somatic attention, a preparedness to take note of personal physical events as well as cognitive and emotional phenomena in response to the process of the analytic encounter. Essential for this also is the place of personal analysis, reflection, supervision, and sharing clinical experience with colleagues, in order to differentiate which of these experiences tell us more about ourselves than about our patients. Through these processes, we can come to understand the patient more completely, expanding our knowledge of not only a particular patient, but also of other people with similar problems. The material I will present relates mainly to patients for whom physical health problems were a central issue. I will then concentrate further on patients for whom the constellation known as medically unexplained symptoms, MUS, was a primary concern. I will illustrate how recognizing my somatic countertransference was central to developing further understanding of their mental life and how I needed to adapt my responses to their needs. But first, I want to offer a brief developmental perspective derived from Anna Freud's work to differentiate medically unexplained symptoms from another group which also present to the clinic with physical symptoms, that is, the conversion disorders. So, physical symptoms and development. Individually, signs and symptoms may be non-specific. To appreciate their significance, we need to identify the link between what Anna Freud called... You're right. It's right. What Anna Freud called surface symptoms and unconscious mental processes. Anna Freud's aim was to ensure a comprehensive understanding of the child's current state of health in context of their wider psychological health in order to, and I quote, draw the diagnostician's contribution away from the child's superficial pathology and return it instead to an assessment of his developmental status and the picture of his total personality. Using a dual approach of linking manifest symptoms and identifying the underlying developmental mental mechanisms which are operating means the clinician can better understand why the immediate symptoms may be occurring in this particular child at this particular time in their life and development. It provides us with a tool which can guide us about whether our therapy is actually helping, despite the child continuing to experience symptoms and perhaps even experiencing different symptoms. To illustrate this, I would like to present an episode from the treatment of a girl whom I worked with through her adolescence. I was initially asked to see Vanessa because she had medically unexplained symptoms. During her teenage years, Vanessa's physical symptoms decreased and her emotional range expanded. At the age of 18, Vanessa experienced depressive symptoms, which she herself linked with the same underlying processes as her previous physical symptoms. This was not simply a gradual or sudden process of the physical symptoms decreasing. There was an intervening episode of physical symptoms which took a different form and which I think illustrate Anna Freud's formulation. So this is some of the clinical work. When Vanessa was 16 years old, when she was on a trip with her mother and grandmother, she suddenly experienced frighteningly intense dizziness. This resulted in neurological investigations, but these did not provide an explanation. Over a period of a few weeks, I was able to disentangle answers to the questions, why now and why these symptoms, and to provide a plausible explanation for what might be happening. Vanessa's grandmother had recently experienced an acute psychological trauma. On the trip, grandmother was returning for the first time to a place which had particular associations to that traumatic event. Vanessa had momentarily lost sight of her grandmother, and it was at that moment that her physical symptoms had struck. The specific symptoms related both to the nature of her grandmother's trauma and to the immediate situation in which they found themselves. I gathered a very detailed description of the episode from Vanessa. We analysed the episode as well as contextualising it in the overall process of her therapy. At the point of experiencing the symptoms, Vanessa was not conscious of any links between immediate and past events, nor was she aware of the significance for herself directly or for her grandmother. Vanessa's symptoms were of feeling dizzy and fearing that she would fall when climbing stairs with a deep drop on the other side of protective railings. On her grandmother's last visit to this building, she had witnessed someone commit suicide by throwing themselves from the top of the stairs. Our careful examination now made sense of why Vanessa had experienced these specific symptoms at this particular time in her development and the family's life. Afterwards, there was an identifiable progress in Vanessa. Originally, in her illnesses, a difficult to describe experience of dangerousness associated with her physical symptoms had been present. This new symptom constellation was very different from the way problems had previously presented. In contrast to the pattern of diffuse symptoms in her previous psychosomatic presentations, this was a dissociative conversion illness episode, as listed in the International Classification of Diseases. The underlying psychical structures and defense mechanisms required to produce a diffuse experience as opposed to a dissociative episode are very different. In the first case, the mechanisms obliterate experience, whilst in the second, they are manifestations of the unconscious compromise formation which manages the internal conflict, negotiating the demands of both external reality and internal unconscious fantasy. Developmentally, the first belongs to an earlier stage of life. I understood the change as evidence of Vanessa's developmental progress. She had achieved the ability to have a neurosis. Over the period of her whole teenage years, Vanessa's problems could be described psychiatrically as moving from MUS through conversion disorder to depression. If we make use of the work of Anna Freud, this developmental perspective can be given psychodynamic flesh. Anna Freud defined the complementary pair of classificatory symptom systems of childhood patterns of symptom presentation. She called these symptomatology proper and other signs of disturbance. Symptomatology proper refers to the underlying intrapsychic constellations which produce manifest problems. Other signs of disturbance is described by Anna Freud as approaching classification by travelling in the reverse direction. The practitioner notes observable behaviour and then travels from these surface signs to whichever upheaval, involvement or failure may be responsible for them. Under other signs of disturbance, Freud grouped together aches and pains, whether they're psychosomatic, hysterical, hypochondriacal, to indicate their superficial similarity as perceived by others and as consciously experienced by the individual herself. Within the class of symptomatology proper, she described a total of 6 groups, but it is only in 2 of these that physical symptoms are likely to dominate. Group 1 includes symptoms resulting from initial non-differentiation between somatic and psychological processes, that is, psychosomatic presentations. Freud's Group 2 includes physical symptoms presenting as conversion neurosis, which requires greater maturity of ego development, leading to symptom formation emerging as a compromise between id and ego functioning. I think Vanessa illustrated developmental progression in line with Freud's classificatory system. In terms of symptomatology proper, Vanessa moved through from Group 1, psychosomatic presentation, to Group 2, hysterical conversion neurosis. Subsequently, she presented with depressed mood in the absence of physical symptoms, and this is described in Freud's Group 4, where symptoms result from changes in the libido economy or direction of cathexis. So now I want to talk particularly about the somatic countertransference. I wish now to turn to occasions when the impact of the patient on the therapist evokes physical experiences, in contrast to those times when it takes the form of thoughts and associations, or making therapists feel as if they are being related to, unconsciously, not as themselves, but as if they are someone from an earlier relationship in the patient's life. So my second clinical example I've called Making an Impact. Leslie was in her early teens when I first met her. I was asked to see her because she was experiencing depressive symptoms with suicidal thoughts, and she had expressed confusion about her sexual orientation. Leslie had been perceived as female at birth, but genital abnormality had been recognized in early childhood. However, comprehensive evaluation and treatment had not occurred. When she reached her teens, her voice had started changing and deepening. Her facial features coarsened, and her body shape changed with increase in muscle mass. She was referred for evaluation, and the diagnosis of incomplete testicular feminization, also known as partial androgen insensitivity, was made. In this condition, the person's sex chromosomes are XY, but in utero and beyond, the body does not respond fully to masculinizing hormones in the usual way to form secondary male sexual characteristics. At birth, the secondary sexual characteristics can appear to be straightforwardly female, but internal female reproductive anatomy is not present. At psychiatric consultation, Leslie presented in a very open way. She was a very engaging person. However, her condition left her feeling lonely and isolated at times, although she did have friendships, and she talked about those friendships' ups and downs with a quality and intensity that felt very much like the preoccupations of most young adolescent girls. In contrast, in looking at her, her physique, the start of coarsening of facial features, and listening to her, the cracking of her voice between high and low, I saw and heard a young adolescent boy. The moment in the consultation when this fully formed mental image of the girl in relationships came together with the visual and auditory image of a boy, I felt it as a physical experience, a hammer blow to the head, and I was momentarily disorientated and shocked. Nobody had ever hit me on the head with a hammer, nor have they in the 35 years since. But I felt a physical impact like I had never felt before. And the only words which have ever felt right to capture the experience are a hammer blow to my head. So where did this experience come from? What does it say about me? Does it tell us anything about Leslie? The only thing I could know definitely was that it was a unique experience which emerged in being with Leslie. The constraints of time mean that I can only refer you to the published case history to see how my thinking about the origins of this experience developed during Leslie's psychotherapy and through my contact with her beyond this. Suffice it to say that, on reflection, consideration of the possible role of transference and projective mechanisms in forming this experience of being with Leslie proved very useful. So my next clinical example I've called a matter of personal taste. The first example involved an experience which was located in one specific area of my body. I want to move on to consider experiences which manifest not only as sensations, but also through a physiological effect. My proposal is that changes in our bodily functioning need to be considered as potential sources of information which can usefully guide our responses to our patients and may give us further insights into their mental life. The following example is from the psychotherapy of Elizabeth, who was 12 years old. Elizabeth's development had been seriously disturbed in all aspects, but it only became clear during psychotherapy as part of her treatment in a residential unit that she experienced auditory hallucinations which contributed to her abnormal behaviour, and that other forms of hallucinations were probably being experienced as well. For example, there were regular occasions when she would flap both her hands and squeal very loudly. She was eventually able to tell me that she was trying to hit away the fucking poo boy who was always saying horrible things to her. I had found out through being with Elizabeth that it was sometimes very important to confirm the reality of a situation. For example, stating that I had heard a noise outside the room helped her differentiate this from other noises in the room and those in her hallucinatory world. In one session, she stood consuming large numbers of pieces of paper and relishing each one, and telling me they were pieces of candy. I sat watching her with my mouth becoming drier and drier until I almost felt like gagging and vomiting. After a while, I expressed my idea that she believed only she could create food that was good to eat. This produced no response. Comparable comments derived from theoretical ideas were similarly unproductive. Finally, I simply and spontaneously said, "They can't taste very nice." She laughed and said no, and the candy was forgotten. The impact of Elizabeth on me at that point influenced the functioning of my salivary glands in a way which would have been measurable. My attempt to manage this intellectually was unproductive. However, making sense of this by engaging with my sensations and translating something of this back to Elizabeth brought her back to her senses. It did not mean that my attempts at interpretive understanding were incorrect, but that they were of no use to her. Later, I reflected on the idea that by being sensible, I was also being sensitive. For example, might I have been implicitly addressing a fantasy being enacted by Elizabeth that she had me as a deprived, envious, hungry baby who must watch a greedy, self-indulgent mother stuffing herself full of lovely food? My implicitly expressed lack of envy in her hallucinatory experience and pleasure helped bring her back to her senses. So my next section is called Reaching for Understanding and Tolerating Not Understanding. The work I'm now going to present in more detail was carried out in my role working with paediatric medical and nursing staff engaged with children suffering from physical symptoms for which no physical diagnosis could be ascertained. These medically unexplained symptoms can produce illnesses which range from being simply annoying but not severely debilitating, through to being life-threatening because of secondary effects. My approach was in a Winnicottian tradition of seeking to identify and mobilize the therapeutic resources which were present in the children, their parents, and those of us engaged with them. The clinical process involved a pragmatic approach to the location of consultations. Sometimes they were in my own consulting rooms, other times in the patient's room or other available rooms on the paediatric ward or hospital outpatient clinic. The form of sessions ranged across individual meetings, child and parent consultations, consultations with other staff, and contact by phone or letter. We didn't have email in those days. I'm going to tell you about two of the children my paediatric medical and nursing colleagues and I worked with, Heather and Vanessa, who you've already heard about. So, clinical examples, the first one of these for this group. Life and death matters, and life and death matters. Our team became involved with Heather when she was 13 years old. I was in contact with her throughout and just beyond her teenage years. Her treatment included some periods of regular twice-weekly individual sessions while she was an inpatient. At the age of 11, Heather had been diagnosed with diabetes. We were asked to see her because of persistent vomiting following a gastrointestinal illness. No cause had been identified for the persistence of vomiting. The combination of profuse vomiting and diabetes was extremely complicated to manage and created potentially life-threatening biochemical imbalances. Heather's vomiting persisted almost without relief throughout the time I knew her, but no cause was ever identified. The paediatrician used the term effortless vomiting to describe it. Heather had been an inpatient for some time when the situation became life-threatening. The following vignette occurred in her room during one of her twice-weekly sessions with me. Heather had been extremely ill when I last saw her. Her heart rhythm was affected by severe electrolyte imbalance, and there were ectopic beats. The nature of the biochemical imbalance meant that if the rhythm tipped over into a more dangerous arrhythmia, it would not be possible to resuscitate her. She would die. I felt it was important to her that I attended as usual. On entering the room, I was met with the usual horrific stench of vomit, and I saw Heather sitting by the window. On the windowsill, just above her head, was a heart monitor. In looking at Heather's face, I was simultaneously looking at her heart rhythm, and I could see on the screen any abnormal heartbeats as they happened. Knowing with any confidence what it was safe to say felt impossible. We sat quietly, but I did make a few comments. These were relatively neutral space fillers, or perhaps attempts at space creators, which were intended as acknowledgements of our immediate presence together and our continuity of contact. However, the effect of even the simplest of comments was displayed above her head by an increased heart rate and increased numbers of ectopic beats. More or less any assertion of myself in her presence seemed manifestly to be a potential threat to her life. Heather didn't say anything, so I could not know what she was thinking or feeling, but her body told a story. This clinical process was no intellectual abstraction of being experienced as a persecutory object. This was the reality of being a threat to Heather's life in doing anything more than simply being in her presence. Never have I experienced Winnicott's differentiation between the importance of being as opposed to doing more emphatically. I will return to Heather later. So my next section I'm calling From Experience to Better Practice. And my first clinical vignette is Who Turned Off the Lights? I'll just remind you of the background to my work with Vanessa. I was asked to see her when she was 11 years old because she had intermittent upper respiratory tract symptoms which had persisted for more than a year, and these were disrupting her life significantly. When she was younger, some different symptoms had been diagnosed as urinary tract infections, but review of the records called these diagnoses into question. There were no emotional or behavioural indicators of disturbance apart from those which appeared to be associated with the consequences of her physical symptoms. Vanessa and her family lived a considerable distance from the hospital, so it was arranged that I would see them for consultations together and intermittently in conjunction with the paediatrician. Following her initial assessment, a significant amount of my contact with Vanessa was by letter. No internet. The consultations with Vanessa were remarkable in how unremarkable they were, apart from a specific pattern which arose in me. I repeatedly became very sleepy during consultations and found myself struggling to stay awake. The sleepiness preoccupied me and disrupted my ability to attend to Vanessa. Trying to make sense of this took me to thinking about a variety of possibilities. Was this the ordinary effect of working whilst having young children whose sleep patterns had not yet become parent-friendly? Or perhaps it was the effect of overall work pressures, or maybe it was a mixture of both. It was some time before I registered that what I was experiencing with Vanessa was also occurring specifically with other children with medically unexplained symptoms. This realization brought out an interweaving of two aspects of the impact upon me, the physiological and the psychological. If I had been wired up to an EEG machine during the work, I'm confident that the tracings would have demonstrated my functional changes from being awake to going to sleep. And even away from the immediacy of the clinical interaction, something else was also being switched off. A significant part of my practice and teaching is about the diagnostic importance of recognizing the impact of the patient on the practitioner. So why had I not tuned in sooner to the possibility of the clinical significance of what was happening? Not only was I being switched off when I was actually with Vanessa, a normal tool I used in my clinical reflective practice, that is, the readiness to consider the possibility of counter-transference and projective processes, let alone recognize and understand them, had been rendered temporarily inoperative. When I became able to consider that my functioning might be being governed effortlessly and unconsciously by processes within Vanessa, I ceased becoming sleepy with her. To use a formulation of Winnicott's, my struggle moved from seeking to retain a sense of physical aliveness, and I regained the ability to be capable of, and I quote Winnicott here, the imaginative elaboration of somatic parts, feelings and functions, which I could use when I was with Vanessa, and perhaps on her behalf as a form of auxiliary ego. In working with Vanessa and other young patients with medically unexplained symptoms, I found that their symptoms were usually focused into particular areas of bodily experience or loss of functioning, loss of sensation or movement, eating difficulties, but that, over time, these may also change in their focus, moving to different areas of the body, perhaps the respiratory system, the digestive system, joints, muscles. Sometimes they may expand into a more diffuse or complete absence of active involvement with the outside world. One girl fixes in my mind as Sleeping Beauty, a term also subsequently applied to similar children by other practitioners. Building on what I took to be, in the most general sense, a counter-transference experience, and my early failure to contain this, I came to conceptualize these illnesses as a hibernation response, which may be seen as a partial or generalized withdrawal from wider activities and interactions. Hibernation is a form of living without the usual external evidence of activity. It is an extreme response which can be thought of as a defense mechanism induced by the absence of key aspects of environmental provision and reversed by external changes which allow the re-emergence of dormant internal psychosomatic resources. It is a manifestation of what Winnicott captured in the formulation of a primary true self, and he describes it comes from the aliveness of the body tissues and the working of body functions, including the heart's actions and breathing. It should also be noted that Vanessa's mother had experienced depression and physical illnesses during her infancy and early years. These affected her emotional availability for Vanessa and her liveliness with her. One can see how this might also have been contributing to my response to her as a more classically described countertransference, a reenactment of those early times with her mother, which I acted out in the countertransference, but from which I recovered. Perhaps this is an example of what Winnicott described as failing, but failing in a manner that the patient needs us to fail. My next section is called Becoming the Embodiment of the Problem. I'd now like to return to Heather to give some further examples of what my work with her taught me about the importance of recognizing the stories my body was telling me. So the first example, watching the detectives. One morning, a few months into work with Heather, I was walking back down the ward after her psychotherapy session, and I found myself thinking about the fictional television detective Columbo. Not only was I thinking about him, I felt briefly as if I was him, walking in that sane, slouched and preoccupied manner. Columbo was not a program I'd been particularly interested in, nor had I watched it more than occasionally, many years previously. So it was perhaps more readily possible to recognize that something had got into me. That is, it related to my clinical work with Heather. There was nothing readily identifiable from that morning's session's content that seemed to have led to this association arising. So as I went to my next appointment, I reflected more widely. Columbo has a particular style. He presents himself in his whole demeanour as unkempt and shambolic. His manner with potential suspects is one of perpetual puzzlement and of being incapable of making sense of anything. His persona is of being someone for whom only questions arise, never answers. Yet out of this scenario, somehow, he creates a situation in which culprits are lulled into errors that make their guilt undeniable. In essence, he makes an art of being the embodiment of not knowing and not being capable of becoming knowing. As a specialist in not knowing, he enacts an impotent, denigrated object. This in turn intensifies the other half of this split in the murderer, omnipotence and invulnerability. The culprit, in the hold of these powerful processes, enacts them and lets their guard slip. Inevitably, they enact their fantasized omnipotence, make mistakes, and give themselves away. This led me to a formulation of a key aspect of this work. I had to become a specialist in not knowing. The practitioner has not only to avoid hibernation, but to remain an alive, awake person who, in the presence of intense, primitive anxieties, remains resistant to powerful regressive pressures in which omnipotent states of mind obscure the ability to see without already knowing, and to cope with uncertainty as opposed to the illusory safety of certainty. This state is captured by a term coined by the English poet John Keats, negative capability. Furthermore, where Columbo was always looking for a culprit, I needed to remain open to less linear lines of cause and effect, to appreciate that a clinical picture is more often an emergent form, crystallizing from a constellation of contributory factors, none of which on their own should be considered the culprit. I call this process negative culpability, which in conjunction with negative capability is a foundation for scientific psychoanalytic practice. The particular setting of work with Heather when she was an inpatient brought about a change in the first meeting point for sessions. Rather than her coming to the clinic and me collecting her from the waiting room, I would go to see her in her room. So my next little clinical vignette is called The Doors of Perception. One morning, after I knocked on the door, and thinking I'd heard her say, "Come in," I went in. She looked up and smiled, but this expression immediately changed to a scowl. In response, I said something to her. What I meant to say was, "Yeah, it's me, a fate worse than death." What I actually said was, "Yes, it's me, a face worse than death." I immediately recognized my error and its import and laughed, as did Heather. I thought that my parapractice emphasized the intense conflict and ambivalence Heather experienced. She did appreciate what I was trying to do and welcomed me. Simultaneously, my arrival as the embodiment of a fate worse than death evoked intense fear. As ever, the task was to respect her intense conflict and, taking this into account, manage my behaviour whilst also avoiding being ruled by her conflict. A further component of this, a demand experienced by the paediatric nursing and medical staff more strongly, was the ability to contend with there being an absence of any statement of appreciation of what we were doing. The conflict implicit for Heather in being in and gaining from relationships subsequently became clearer in her relationship with horses. They had always been especially important to her, but during her illness, one particular horse took on an added importance. When she was well enough, Heather looked after this horse meticulously, caring for it and caring intensely about it. When she was with him, she also found some peace and a form of asylum. However, as her symptoms and her need for comfort intensified, she found that this all became too difficult, since finding comfort in this relationship evoked in her a conscious feeling and belief that she was exploiting the horse. At this point in her life, there was no win-win situations. Despite her horse seeming to enjoy what was happening, for Heather, finding comfort in this relationship could only be taking comfort from her horse and leaving her horse depleted by their relationship. My next section is called Making Space for Thinking and a Meeting of Minds. As Heather's physical state became more dangerous, her sessions became characterized by an almost total absence of spontaneity in her. Tolerating silence can be crucial in practice, but there is also a danger that it becomes an enactment by a therapist of the conflict of having a life but not daring to show it. I had to learn how and when to demonstrate to Heather that I was truly alive and not hibernating, with a mind present and working for her, without further intensifying her conflicts about being with me, and one of both of us suffering a fate worse than death. So the next clinical vignette is called Finding Inspiration from Desperation. The unusual clinical setting meant that I saw the things she had in the room with her. I noticed she was reading Lord of the Rings. I had read and enjoyed it many years earlier. I commented on it, but without any reference to my enjoyment of it. The interchange about the book did not last long, but the book became a reference point for us. I took a position that for her to read it meant that she would have an experience of it, and in that experience we might find a rendezvous point. This, in turn, might help in understanding her in her illness. Heather was very limited in what she could say about the story, even in as far as describing the content, let alone reflecting on it. This put me in the position of having to draw explicitly on my own memories of the book, and I decided to introduce gradually into our conversation more of what I pieced together about its possible significance. This meant that I was taking the initiative in a way that would not usually feel correct in psychotherapy. However, it felt necessary if I was to be of use to Heather. So, learning from Gollum. The central issue in Lord of the Rings is the unusual powers the ring bestows on its possessor. When worn on the finger, the ring makes the wearer invisible. It has the potential to be a life-saving defense. It not only alleviates fear and anxiety, it evokes in the previously feared object that state of terror. The victim becomes the predator, and the predator becomes the prey. However, the defensive capability of the ring also contains a destructive influence. It takes on a life of its own. It becomes a possession which possesses the wearer, both in having it and through using it. Ultimately, this power corrupts the physical form, relatedness, and the moral integrity of the wearer. Tolkien summarized Gollum's relationship with the ring. He hated it and loved it as he hated and loved himself. He could not get rid of it. He had no will left in the matter. Ultimately, Gollum, corrupted physically and spiritually, died because of his desire to regain ownership of the ring. So if we think of this as a ring defense, my thinking about the ring as representing the nature and influence of primitive defense mechanisms is very much shaped by Winnicott's description of the true self and false self, and by Grodek's earlier formulation of the it. In extremis, such defenses can temporarily protect against an overwhelming threat of disintegration whilst preserving developmental potential. However, if they persist, they become a corrupting force on the developmental processes. They can be compelling and addictive, dissipating primitive anxieties whilst distorting development. The difference between the ring defense and the hibernation response is in the way in which the body is maintained as a primary focus in relationships. In hibernation, the active presence of the body remains in view, in the eye of the beholder. The ring defense needs and perhaps seeks to have a potential presence without physical form, an invisible presence, out of sight but not out of mind, and very much present as a threat to the eye of the unbeholder. For Vanessa and youngsters like her, their illness symptoms remain circumscribed, encapsulated in bodily areas of functions. But in evading diagnosis, they remain unnamed. One can conceptualize these as identifiable constellations residing within the body as semi-autonomous characters, which sometimes migrate to produce different effects. The approach I had been taught was to acknowledge the fact that doctors did not have good names for their illness, and to offer the youngsters a chance to give it their own name, so we could use this as the diagnosis. Vanessa's ear, nose and throat symptoms, called Bert, and they became absent when she suffered an ankle injury. This injury had occurred after we'd been discussing where Bert lived when he wasn't in her ears. After she suggested it went to her big toe, Vanessa's big toe had been injured, leading to her slipping when walking down the stairs and hurting her ankle. We played with this as Bert taking up residence in her demonstrably injured ankle and finding another way to assert his experience. However, for other patients, the interaction of their internal and interpersonal psychological or physical processes may dissolve the containing capsule. In Heather's case, if she had not had diabetes, a vomiting illness might perhaps have remained as an isolated episode. However, the interaction produced cascade effects which took on a life of their own and threatened her total existence. So my last section is called Building on Experience and Creating a Rendezvous Point. Lord of the Rings became central to my thinking about Heather and the nature of the defence mechanisms involved in the other children and adolescents I came across with severe medically unexplained symptoms, including those with eating disorders. Using the story explicitly, describing what it brought to my mind around the dilemmas and suffering they might be experiencing, even without them being familiar with it, seemed to create a rendezvous point with them, offering some degree of safety, even if it wasn't without conflict. The patients seemed to be better able to experience me as by their side and on their side, rather than our relationship being one in which there could only be one outcome, one or other of us negated or destroyed. The complex clinical engagements I've described did not provide the opportunity for the in-depth exploration and understanding that an emergent analytic process can provide. In consequence, one is left more explicitly with one's own conjectures about the psychodynamics without the help of further evidence of the unexpressed components of the patient's internal world. My overall practice was significantly dictated by our service's resources. But I think that for these patients with medically unexplained symptoms, where the ability of the psyche to function robustly in the task which Winnicott described as the imaginative elaboration of somatic parts, feelings and functions, I think it's impaired. The patient's needs demand different responses from the therapist. At times, I had to be prepared spontaneously to offer more of the imaginative elaboration of my own psychosoma, which required better recognition and understanding of my own somatic experiences emerging from the impact of patients on me. My practice has been most influenced by the theoretical formulations of Anna Freud and Donald Winnicott, which emphasize the psychosomatic integrity of being. Their models are grounded in and emerge from the reality of minute-by-minute infant and child care. In describing developmental stages of oral, anal, genital, and Oedipal, Freud defined an indivisibility of anatomy, physiology, and relatedness. Psychoanalysis as a descriptor of human development and experience, and a tool to alleviate suffering, must not simply be an intellectual abstraction. In the therapeutic process, the analyst can neither be entirely stripped of personal identity nor disembodied. Nobody can have nobody. Should we change seats?
No, I'm very good.
A continuación, Gonzalo López, psicoanalista, profesor de nuestro diplomado, va a comentar el trabajo del profesor Sutton.
Hola, buenos días. Voy a acercarme al micrófono porque estoy un poquito ronco, pero vamos bien. Perdón, me había olvidado.
It's called finding a voice.
Yes. La última frase que dice el doctor Sutton en el trabajo dice: nadie puede no tener cuerpo, que fue como se tradujo. Yo preferí ponerle, y el nombre de mi trabajo se llama No hay lugar para el no cuerpo. Hice una pequeña modificación que me parecía que le daba un sentido a lo que ocurre muchas veces en el trabajo psicoanalítico. Quisiera iniciar este comentario diciendo que me puso en un apuro debido a la gran cantidad de conceptos y experiencias clínicas muy relevantes, aportadoras y novedosas, incluyendo ideas personales y una práctica íntima del propio autor del texto. Me encontré con uno de esos textos que uno desea estudiar y termina subrayándolo completo, por lo que inicialmente el resultado sería volver a leer lo mismo que el doctor Sutton ya nos compartió. Dicho esto, voy a hacer una selección personal de subrayados para invitarlos a compartir con el autor sus comentarios y preguntas. Un primer aspecto del artículo que me llamó la atención es la introducción de los síntomas médicamente. Voy a cambiar la palabra porque me parece que se ajusta mejor a lo que significa unexplained, que es inexplicados, no inexplicables, porque en realidad en algún momento se van a poder explicar, no son inexplicables. ¿Ya? Síntomas difusos y la diferencia con la conversión y el lugar diferente del analista respecto de estas manifestaciones observables en la clínica de pacientes internados y el impacto en el terapeuta, su contratransferencia somática, y lo que llama, y también hice un pequeño cambio, experiencia somática parejamente flotante. Me parece que pone más de manifiesto la manera como el analista está somáticamente frente al paciente. Disponible para ser usada no como contenido a interpretar, sino que como voz ofrecida al paciente sin voz, sin poder nombrar o integrar a su caudal representacional, reconociendo la necesidad del terapeuta de adaptar sus respuestas a sus necesidades. Quisiera destacar el uso de la palabra necesidad, need, trayendo la diferencia aportada por Freud, primero con su palabra interés en relación con la pulsión de conservación y luego destacada por Winnicott en relación a aquello que debe ser cumplido y no interpretado. La diferencia, entiendo, entre estos síntomas difusos, necesidades del paciente sin voz, pero traídas por el síntoma difuso y sin algo claro con qué relacionarlo, tanto médicamente como interpretativamente, y el deseo, síntoma conversivo a ser interpretado por el analista. En este sentido, nos plantea que la estructura psíquica de base y los mecanismos de defensa requeridos para producir una experiencia difusa como opuesta a una conversión son muy diferentes. En la primera, los mecanismos borran o anulan la experiencia, en ese sentido tiene algo de la desmentida, y pertenece a una etapa más temprana, mientras que en la segunda son manifestaciones de formaciones de compromiso inconsciente que manejan el conflicto interno. Nos da un ejemplo de esto en el caso Vanessa, donde relata en su delicado y sensible trabajo un avance desde síntomas difusos a conversión, donde logra la posibilidad de tener una neurosis y una depresión. Entonces entramos en el campo del impacto. Nos impacta con sus relatos y su creatividad clínica al hablarnos del impacto en el terapeuta debido a que el paciente le evoca experiencias físicas, en contraste con aquellas evocaciones que toman la forma de pensamientos y asociaciones, o bien haciendo sentir al terapeuta que está relacionado con el inconsciente y no como ellos mismos, sino que como alguien de la vida temprana del paciente, lo típico de la transferencia. Nos habla de sensaciones físicas concretas, incluso nunca antes vividas por el analista, pero que hacen un relato y no una representación, una sensación directa y no el contenido de un sueño a ser interpretado, dado que esta interpretación haría el efecto de una intrusión violenta y perturbadora de la relación analítica y provocadora de dolor y daño para el paciente. Por ejemplo, nos cuenta: sentí la experiencia física de un martillazo en la cabeza quedando desorientado y choqueado. Experiencia única surgida al estar con Leslie. Frase que en sí misma resulta muy aclaradora de la diferencia que estoy muy torpemente tratando de resaltar. Quisiera entonces detenerme en otra propuesta que me llamó la atención por su simpleza, pero también por su profundidad en la clínica, respecto del uso de nuestras reacciones y sensaciones corporales en pro del paciente y del uso de la interpretación. Hace una acotación, como al pasar, donde dice las palabras being sensible and being sensitive, sensato y sensible. Al ser sensato, estaba siendo sensible. Sensatez en el sentido de adaptación y de no pedir al otro lo que no puede dar, no decir lo que no puede entender, no esperar lo que no es sensato esperar, no interpretar cuando no es sensato hacerlo, o sí interpretar cuando lo es. Me parece no haber escuchado nunca antes a algún autor hacer esta relación, que resulta tan evidente cuando uno la escucha, tan cercana a la experiencia de cada uno, pero a la vez tan compleja y fácil de perder con el uso no sensato y por lo tanto no sensible de la técnica o de los afectos de manera sentimental en el decir de Winnicott, o de las herramientas del psicoanálisis sin cercanía con el paciente y de su condición concreta durante la regresión, dependiendo de su estado regresivo. Pensando en esta propuesta, quisiera mencionar lo planteado en un trabajo previo mío de Bombas sobre Londres, donde trabajo la escucha del analista y el esquema referencial que se la permite, y en la gran ampliación que este trabajo del Dr. Sutton ofrece a la escucha. El oído del analista al cuerpo del paciente y las resonancias, los ecos que éste produce en el propio cuerpo y que han pasado desapercibidos al no incluirlo como un relator de historia, sino que solo como el lugar del deseo, de la pulsión y de la conversión que manifiesta el deseo reprimido. Creo que Winnicott y otros autores han contribuido no solo teóricamente, sino que en una afinación nueva para así abrir el oído de los analistas a sonoridades previamente no consideradas en la práctica del psicoanálisis. Incluso el Dr. Sutton se pregunta respecto de la técnica en regla al poner sus propios recuerdos del Señor de los Anillos a disposición del olvido de esos contenidos por parte de su paciente. Cuando Rachmaninoff estrena su primera sinfonía, fue un fracaso rotundo. Fue catalogada como, comillas, sonidos para el infierno, por otro gran músico ruso. Sin embargo, abrió el oído de las generaciones posteriores a sonoridades desconocidas que hoy nos deleitan. Lo mismo ocurrió con Beethoven y su sinfonía heroica, imposible de tocar, demasiado ruidosa. Creo que el Dr. Sutton nos muestra una sonoridad desconocida en nuestro medio, con el trabajo con pacientes con síntomas médicamente inexplicados, diferentes a las conversiones, lo psicosomático o lo hipocondríaco, cuerpo real y no cuerpo del deseo. Por ejemplo, nos dice algunos comentarios como para llenar espacio, pero también podrían haber sido para crear espacios, como reconocimientos de nuestra presencia juntos y nuestra continuidad del contacto. No espacios liberados desde lo reprimido, sino que espacios del estar con el paciente de una manera sensata y sensible, escuchando sus latidos cardíacos, con un oído privilegiado, como los médicos antiguos que ponían su oreja en nuestra espalda para escuchar el corazón y los pulmones. Dice, pero aumentaba el ritmo cardíaco, por lo que cada afirmación mía en su presencia parecía ser sentida manifiestamente como una amenaza potencial a su vida. Su cuerpo, su corazón, contaba una historia. No era una abstracción para ser decodificada de manera intelectual, para ser mostrada como un objeto persecutorio. Era la realidad de ser una amenaza para su vida al hacer algo más que solo estar en su presencia. Gran muestra de la diferencia de Winnicott de ser y hacer, como nos dice el Dr. Sutton, con la que estoy de acuerdo y nos refiere a la adaptación del analista al servicio del paciente. Voy a insistir de nuevo en la gran sutileza de la idea de sensatez, de contacto permitido por las nuevas posibilidades del analista a través del contacto con el síntoma de la paciente. Comillas, dice el Dr. Sutton, pude recuperar mi capacidad de la elaboración imaginativa de mis funciones y partes corporales. De aquí la importancia de reconocer las historias que mi cuerpo me estaba contando. En este momento me voy a detener en dos ejemplos seleccionados por mí que nos trae el Dr. Sutton de lo corporal, en el caso Columbo. No sé si todos saben quién es Columbo. Sí, ¿no? ¿No? Columbo, I'm going to explain who Columbo is.
You've got to stand up and do it.
Yeah. Columbo es un detective de las series de televisión de los años 60, 70, que era muy desmañado, caminaba era como muy desordenado y que actuaba siempre como si no entendieran lo que le decían. Era como desordenado intelectualmente, aparentemente poco astuto, tenía un caminar muy particular que es el que el Dr. Sutton descubre que está, ¿no es cierto?, viviendo en este caminar que nos comenta. ¿Ya?
Yeah, and the cigar.
And the cigar, yes. Y tenía un cigarro. Era una serie muy... Sí, además tenía un ojo más chico, era como todo mal con el doctor, con el detective Columbo. Un impermeable que no se cambiaba nunca, era... Ya. ¿Sí? Y de la memoria, el primero sobre el cuerpo, Columbo, y el segundo de la memoria, el Señor de los Anillos. Se encuentra caminando como el personaje de Columbo. Me trae recuerdos de mi infancia y de mi juventud de una serie que me encantaba, por razones que el Dr. Sutton relata extraordinariamente bien, pero al servicio de su paciente. Yo solo veía los domingos en la tarde con la angustia siempre presente de no haber hecho las tareas. Y obviamente sin lograr ninguna de estas asociaciones respecto de la capacidad negativa y la culpabilidad negativa. Columbo hace un arte de no saber y no ser capaz de llegar a saber, nos dice el Dr. Sutton. Escenifica un sujeto impotente y denigrado, lo que intensifica la otra mitad de esto en el asesino, la omnipotencia y la invulnerabilidad. Ejemplo de analista como... El culpable baja la guardia, comete errores por esta omnipotencia y se entrega. Ejemplo de analista como sujeto que se especializa en no saber, poder enfrentar la incertidumbre como opuesto a la seguridad ilusoria de la certidumbre. Keats lo llama capacidad negativa o bien Bion con la tolerancia a la incertidumbre y a la no saturación por angustia del analista. Sin embargo, en la clínica y el trabajo con los pacientes no hay culpable, hay constelaciones de factores que contribuyen, lo que le da nombre a la culpabilidad negativa. Interesante concepto que nos trae el doctor Sutton. He citado detenidamente porque la propuesta de la culpabilidad negativa es un aspecto relevante en la clínica actual del trauma y de los aspectos traumáticos. Proponer un culpable de manera anticipada o a priori alivia al analista de la complejidad de la constelación de la culpabilidad negativa. Siguiendo el texto de Freud sobre el psicoanálisis silvestre, nos advierte en contra de las soluciones rápidas, más para aliviar la dificultad del analista de tolerar la incertidumbre que para aliviar el sufrimiento del paciente. Llenar con sexualidad, abuso, trauma, pero a priori. Les comento, un analista respecto del relato de una paciente le pregunta: ¿no será que usted fue abusada de niña? Esto muy temprano en el inicio de las sesiones. Nos dice Sutton, ambas capacidades, y esto lo encuentro muy relevante, son la base para una práctica psicoanalítica científica y, a mi entender, el a priori le resta dicha condición a nuestra práctica. Impide que ocurra lo que nos dice el autor, respetar su intenso conflicto, pero sin ser gobernado por este. En el segundo ejemplo, la paciente le relata que leía El Señor de los Anillos, pero ella no lo recordaba y dice: me vi en la necesidad de poner los propios recuerdos de manera gradual en la conversación. No parece correcto en terapia, pero sí lo es si es útil para ella. Cumplir versus interpretar, neutralidad, sugestión, gratificación del deseo, todo esto en juego en este simple acto del analista en favor y resguardo del trabajo con su paciente. Gran ejemplo de clínica psicoanalítica a mi modesto entender. Recordar y pensar en los contenidos metabolizados por el analista permite que el libro sea un punto de encuentro que ofrece algún grado de seguridad, aunque no sea sin conflicto. Paciente que me experimenta a su lado y desde su lado, y remata el trabajo diciendo: no debe ser solo una abstracción intelectual, no hay lugar para el no cuerpo. Gran final que da inicio a este comentario. Gracias.
Thank you. Thank you. Melanie is going to
Hola,
answer.
Melanie. ¿Cómo estás tú? Bien, gracias. Yo creo que aquí al medio, ¿no? Sí, no, al otro lado.
O sea, yo voy para allá y yo voy para allá.
You're right. You okay?
Yes.
En función del tiempo que tenemos y considerando que es importante el intercambio para hacer con el profesor, lo que sugerimos a continuación es si el profesor quiere decir algunas palabras con respecto a lo comentado por Gonzalo, y iríamos después de eso al café para volver a hacer el intercambio ya con más calma.
Entonces, if you, because of time, they prefer you to, if you have any answer or any comment about what Gonzalo said, to comment it now, and after the coffee break, they can do the questions.
Okay.
If you have
So-
any comment about what Gonzalo said.
I don't want to take too much time with comments because I don't want to take too much time with comments myself
No quiero,
because what we're hoping is for a conversation.
no quiero tomarme mucho tiempo yo dando comentarios acerca de lo que comentó Gonzalo, porque quiero dar más espacio a ustedes a poder tener conversación con ustedes.
It's an incredible privilege to have people read one's work in such detail.
Es un tremendo privilegio poder tener tanta gente leyendo el trabajo de uno en tal nivel de profundidad y de detalle.
And it's also a wonderful experience to work with translators who think so carefully about one's words as well.
Y también es un privilegio trabajar con traductores que piensan detalladamente qué es lo que uno está diciendo.
And Gonzalez, you pick out some key points which are so important to me, and that's about being able to triangulate ourselves with our patient.
Y Gonzalo, tú recoges un par de puntos que son muy importantes, que tienen que ver con cómo nos triangulamos con el paciente.
So how do we know where we are? We need to be able to have a sense of our place in order then to understand our patients. So we use the thoughts of our colleagues. And then also we can use theory. I'm not against using theory or intellectual activity. These things help us place ourselves in relation to our patients.
Entonces tenemos que pensar dónde nos situamos nosotros como terapeutas en relación a nuestro lugar, en relación a la teoría y a nuestro paciente, dónde nos situamos ahí.
So I'll just quickly, ser sensato y ser sensible.
Sensato y sensible.
You made me think, listening to you saying it, that is this the example of something that that Winnicott describes when he says, there are these things just there waiting for us to find them. And at the same time, they bring together something new inside ourselves. So there's a new creation. We create it, but it was just there waiting to be found.
A propósito de lo sensato y sensible, me hace pensar cuando Winnicott habla acerca de que hay cosas que están ahí en el espacio por aparecer, por ser dichos, por ser usados, como ser sensato tiene que ver con eso, con poder hacer uso de esas cosas que están ahí.
And listening and thinking with you also, it makes me wonder about a phrase I came to use with children when I was being more active. Do you want to say that?
Sí, me hace pensar en cuando he trabajado con niños, cuando he estado trabajando de forma más activa.
I put myself forward more early with them.
Me pongo ahí al frente con ellos más temprano.
So I would say I'm a specialist in not knowing.
Entonces yo diría que soy un especialista en no saber.
And what was interesting was that the children, it made complete sense to the parents.
Entonces a los niños esto les hacía perfecto sentido, fluía con ellos, pero los padres quedaban ahí perplejos, no entendiendo.
So right this moment I have a new thought. Is it that we have to really, truly become children and childlike again?
Me hace pensar que entonces tenemos que probablemente trabajar siendo un poco más como niños de nuevo.
But I formed a way of saying I would describe some of my thoughts in the way that I've told you about them. And then I would say, and does it sound anything like you that I'm talking about, or even a bit like you?
Sorry. Si es que...
Sí.
¿me
Dice que si esto les suena de alguna manera como algo que son ustedes, o que podrían ser ustedes.
And the last point I'll make is to agree with you how important it is not to define people by events.
Y por último, un último punto importante es, creo, la importancia de no definir a las personas por sus eventos.
that I think we need to start by trying to understand the person, not to define the person by the event.
Tenemos que intentar entender a la persona, no definir a la persona por el evento.
And it is interesting that services develop and want to be able to define themselves tightly like that by events. At the same time as some of the people who have suffered those events as might say, I am not going to be identified by this event.
Hay una tendencia que las instituciones, los sistemas buscan entender, categorizar a las personas, pacientes, por esos eventos, cuando justamente los pacientes lo último que quieren muchas veces es ser entendidos y determinados por ese evento.
That's all I want to say.
Eso es todo lo que me gustaría decir.
Muchas gracias. Entonces vamos a hacer un pequeño break para la gente del Zoom en unos 20 minutos.
Thank you.
Thank you.
Well done.
Now you can sign.
Now.